righty, welcome everyone. We hope you all have had a fantastic week thus far, and we hope that that momentum only continues. We are so excited to kick off today's program, which will focus on telemedicine and telehealth and how they've both shaped the way transplant programs facilitate their clinical practices despite the COVID-19 outbreak. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to host today's program in collaboration with our moderator, Laura. Now, before I go ahead and turn it over to Laura to introduce today's presentation, I'd like to quickly review a few housekeeping items with all of you. Now, upon joining us for today's webinar, you may have noticed that your audio lines have been muted. This is to help us ensure that we have the best audio quality for our presenters. That said, please take note of the Q&A feature located in the Zoom navigation bar at the very bottom of your screen. All of your questions for our presenters should be submitted here. Once the presentation has concluded, we'll go ahead and transition into our Q&A discussion, where our presenters will address as many of your questions as time allows. Now, for anyone interested in our upcoming webinars, we are excited to announce our next donation-focused webinar, which will highlight creative communication strategies for family support coordinators to consider when facilitating donation conversations with potential donor families. Now, if you're interested in learning more, you can join us for that presentation on February 9th at 2 p.m. Eastern. Registration for our next transplant-focused webinar is also open. This webinar will highlight methods for expanding the donor pool through the use of DCD hearts. Be sure to join us for that on February 23rd at 3 p.m. Eastern. Now, as always, to stay up to date on all of our upcoming programs, we encourage you to visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you are all eligible to claim continuing education credits. For this webinar, we will be offering 1 CEP-C credit and 1 nursing contact hour as a result of your participation. Additionally, a certificate of attendance is available for those of you who may be seeking CEs that are not available. Prior to receiving your credits and certificates, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you happen to be listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits. Now, without further ado, I'd like to go ahead and introduce our moderator formally, Laura Hanpeter, Transplant Program Manager at Nebraska Medicine. Laura, it's such a pleasure to have you with us today. And at this point, I'll go ahead and turn it over to you to introduce both of our presenters.
Great, thank you, Deanna. Very excited to introduce our 2 presenters today from Thomas Jefferson Kidney Transplant Program. And they have a wonderful presentation prepared to talk about how they've been able to efficiently navigate the pandemic through the use of telemedicine. Dr. Pooja Singh is the Associate Professor, Medical Director for Kidney Pancreas Transplantation and the Medical Director for Kidney Transplant. And also Dr. Anju Yadav is the Assistant Professor, Internal Medicine and the Assistant Director for Living Kidney Donor Program and part of the Division of Nephrology, Hypertension, and Transplantation. So I will let them continue on with the presentation today.
Hi, good afternoon. Thanks, Deanna and Laura. And I would also like to thank the Alliance team to giving us this opportunity where we can share our experience. I would also like to thank Dr. Singh and our university who helped us through this pandemic and provided us with the resources. Last but not the least, I would also like to express my gratitude to our patients because we try to do our best for them, but without their partnership and their participation, none of this would be success. So with that, I would start. The learning objectives from this webinar are basically, we should be able to describe telehealth and telemedicine and differentiate between the two. Although they both are used interchangeably, but there is some difference in them. And then describe, why do we need and what are the benefits of using telemedicine? Describe our workflow, which helped us through this pandemic. And every university, every place has their own workflow based on what technology they have, what infrastructure and personal they have, and what are the institutional policies. The aim of this talk is to just share our experience and share what worked for us and how we used tele before and during COVID and how we are doing now and how we changed our workflows to kind of accommodate. Now that the fact that we're having this discussion is that tele is not, very well adopted in different centers and has its own barriers to its use. And these barriers can be patient-based, physician-based, or institutional-based, and we will be discussing those at the end of this talk. So without much ado, let's start the discussion. So we have me and Dr. Singh. We don't have any conflicts of interest, and we have nothing to declare pertaining to this webinar. So, how do we define telehealth? We all have our understanding of what telehealth and telemedicine does, but what does actually CMS? How does CMS describe it? So they describe it at any kind of patient and doctor relationship, which is two-way in real-time interactive communication with an audiovisual tool, is defined as telehealth by CMS. And it should be using a HIPAA reliant or HIPAA compliant audiovisual platform. And this definition also includes the type of technology that we are using. It should have an audio component, a video component, and it should be HIPAA compliant. Now, this can vary with each institute, as well as, as long as we have an audiovisual platform, it can be defined as telehealth. Um, as I said, we use telehealth and telemedicine kind of interchangeably, and for the most part, it doesn't matter what word or what term you're using, because it doesn't change they're very distinct, but it doesn't change the outcome as long as we are doing what we're supposed to do, provide the healthcare services in in an appropriate way, especially during pandemic when we were also challenged. So the Health Resources and Services Administration, HRSA, defines telehealth as the use of electronic information and telecommunication technologies to support long distance clinical healthcare, patient and professional health related education, public health, and health administration. So telehealth is kind of a broader term when compared to telemedicine, as it also kind of incorporates a remote healthcare services, which can involve nurse practice, advanced practice providers, nurses, your dietitian, social workers, and so on and so forth. Telemedicine is specifically the between a provider and a patient communication and the healthcare that is provided. So those are kind of a very subtle difference, but at the same time, it's a very significant difference between them. What is the telemedicine? So whatever term we use, we practically, basically it's not just a technology. Telehealth is more about the workflows and the operations. It's not just a technology. It brings a lot of questions. It's the first question that we all ask is telehealth better than an in-person visit? Well, it maybe depends on the question itself and the reason why we are using telehealth in pandemic. And when we were challenged with the COVID, if the patient is relatively stable and who might or might not have a financial or time challenges, might be benefiting from a telemedicine. During the pandemic time, if the patient is really sick and they are highly suspected of COVID infection, they probably should not come to the clinic, and they should be probably seen by a telehealth platform first before asking them to come. Is telehealth better than no visit at all? Absolutely. You would rather see patients on an audiovisual component rather than come to your clinic when they're really sick or are suspected of COVID or not get any care at all. The next critique that telemedicine gets is there's no physical exam, you're not touching the patient, you're not examining the patient, but you are actually doing a physical exam, and we'll go in detail about this at some point. There this You can get a lot of information on a telehealth platform when you compare it to office visit. You're just not touching the patient, that's the only difference, but there's a lot of other data that you can gather, and you can assess the patient. And it is about actionable information. You can get all the information that you need to take care of your patients and do what is the best. Why are we talking about telehealth so much? So it has shown to improve the adherence. And there was a study published in American Journal of Transplantation. It was done in Germany. They looked at their 1 year post-kidney transplant patients, and they divided randomly into two groups. So it was a randomized controlled trial. Half of the group got set up, they got the standard of care. They had their clinic visits. They were followed up like they always did. And the other half of the group was set up in a telemedically supported case management group. So this group had their physicians, their social workers, coordinators, dietitian, everyone communicate on a regular basis with their patients. And they saw how the two groups fared. So the way they assessed was what they call is the composite adherence score. They looked at how patients were, doing in terms of their chronic care, in terms of taking their medications, in terms of their how many of these patients required unplanned inpatient acute care, or they looked at the cost reductions and so on and so forth. So they saw that in 1 year post-transplant, patients who had a telemedicine supported group versus the standard of care group, in 1 year, only 17% of the intervention group had non-adherence seen or observed, compared to almost 57% of the patients who received standard of care group had non-adherence. So if you look at this graph clearly, in 1 year time, patients who were supported by telemedicine had better outcomes in terms of their adherence to their medications and the recommendations. So it has been well studied, and it was well studied even before we were hit with the pandemic. In the same study, they showed that at 1 year time, there were decreased admission rates at 1 year post-transplant. So in these are the two graphs. One of them talks about unplanned admission rate, and the other one talks about the unplanned stay in the hospital, so the inpatient stay. The dotted line is the standard care group who were followed, which is the standard of care. And the bold line is about the telemedicine supported. So you see that most of the patients were almost kept, they did very well when we talk about the how many days they spent in the hospital, or how many patients were acutely admitted to the hospital. So telemedicine is not new. It has been there, and it has been shown to benefit in all types of post-transplant care. But why don't we have a better acceptance of this telehealth in US, or in general? So why don't we adopt more and more of telehealth, and why did we need COVID to remind us of this platform? Because it is very complex. It is as complex as this figure. You can't read it, I can't read it. And that's how complex the system is, that it makes us not to accept it. So it has different components. It had where before COVID happened, before this pandemic happened, to get a patient to be seen by on a telehealth platform and to get reimbursed from it, there were different components which had to be fulfilled. It depended on which state we are talking about, what is the state the physician is licensed in, where is the physician physically present, where is the patient physically present. Historically, telemedicine used to be that a physician and the patient both have to be at a specific designated site, wherever close to their hospital or their home, and they both had to be at the same time on those telehealth HIPAA compliant platforms to complete that visit. So it was very complex by design. That's why private payers were not paying for it. Medicare had all these strict rules, and that's why I think it was not very well accepted until COVID happened. This was a brief slide from 2018. It was published in one of the surgical journals about about difference in the regulations and the policies in different states. So within United States, every state has a different policy, different regulations. They are, certain states which require have different definitions. First of all, they require specific locations. They require informed consents. Some of them cover the facility fee, some of them don't. And they had these strict, rules about online prescribing, who can, who will get reimbursed, who will not. Private payers were not doing it. Before this presentation, I looked up the new rules, and still every state has a different rule in spite of CARES Act and everything else going on. Still, every state has kind of different guidelines and different parameters. They are covering one sort of telehealth, no video calls, no phone calls, and vice versa. So it's complicated. It was very fragmented rules and regulations. So I think that was the biggest barrier at that time. And with that, I would pass on to Dr. Singh, who will tell us how we were doing before COVID happened and how we adjusted our workflows and what we did during COVID. So on to you, Dr. Singh.
Thank you, Dr. Yadav. And thank you for going to the next slide. So I'm excited to be here. And what I want to start with is first telling you that telehealth for Jefferson Transplant Institute is not new. We have been doing telehealth since 2015, and we were primarily using it for our living donors. So we had a living donor who was in a different city and wanted to donate to a loved one or a friend who was listed with us. Rather than have that living donor come to us, get a workup done, meet everybody, take time off, then go back, and then schedule the surgery and make a second trip, we thought, hey, what we'll do is we'll do your complete virtual workup through telehealth. And we had a schematic that we followed. We had the donor complete a health questionnaire remotely. We had them go to a local lab, get some basic labs done. We also got them to see a PCP. If they did not have one, sign up for a PCP, get a physical exam done, and get those facts sent to us. Our team would contact the donor. This would be a coordinator, a social worker, our ILDA, a dietitian, and we would do a full virtual workup, remote workup for that donor, including our transplant nephrologist as well as our transplant surgeon. Then we would present the donor in our listing meeting. We even had these donors go to their local transplant center and get the CT scans done. And if we thought that this donor was going to potentially work out after the virtual presentation, we gave them a provisional yes. We came up with a surgical date and we said, okay, good to come down to us. And they would come to us about 10 days before. And then we would pack in all these appointments in person for that donor. It was intense, but instead of making them do this twice, they could do this all in one shot within a 2-day span of every appointment done in person with the final presentation, including pre-admission testing done a week before surgery. There were many advantages for the donor, not taking time off from work, not using vacation, not arranging for childcare, travel expenses, hotel expenses, so on and so forth. So we had a lot of success with this. And if you could move to the next slide, please. We decided that we were so happy with what we had been doing that we really wanted to share and let everybody know that, hey, we have been doing it and we've had great experience as well as success. So we put this in last year, not actually, this is not last year because last year was COVID. 2019, December, we submitted this to American Transplant Congress. Our abstract got accepted, and this is where our telehealth experience was. Now, this is all before COVID. So we had done about 19 remote telehealth evaluations, 12 of them ended up in donation. And what I want to point out here is it's not only the person who wants to donate and pans out as a donor finds this platform very useful. Those who are not going to work out as a donor, this is advantageous for them too, because they did not have to make the trip down. So the advantages go both ways. An average donor does spend maybe up to $5,000 for various direct and indirect expenses. And this was our way of showing that perhaps this platform gets us a little bit closer to making living donation financially neutral for the donor. We're not there completely yet, but at least it helps because it makes it more convenient for the donor to be able to donate or go through this process, and it simplifies it for them. So this was our experience that we have been very proud of, and we put it in and we did submit this and we showed it in American Transplant Congress, but American Transplant Congress last year was in June and COVID had already started by March. Next slide, please. Thank you. So I want to talk a little bit about the CARES Act that Dr. Yadav did touch upon. And we are all aware of the traditional boundaries that exist with the state regulations, the federal regulations, and what she was mentioning about was the federal mandate that due to the CARES Act, the traditional boundaries have been taken away. Having said that, it's really important to know your state rules, and ultimately you do have to follow your state rules. And the expanding access with healthcare during COVID truly happened because of the presidential emergency that was declared, which was backed by the HHS secretary. And this led to what we call as the 1135 waivers, due to which we were able to do, and we are still able to do many of the things that we could not do before in terms of crossing state boundaries and practicing telehealth. Next slide, please. So the CARES Act is a leniency that's given in terms of the licensure requirements, the telemedicine reimbursements. Before COVID, Medicare was not covering telehealth reimbursements. Now they are. In fact, the first few weeks when COVID happened, the Medicare telehealth visits increased rapidly from about 100,000 visits a week to 300,000 visits a week. And the CMS administrator that time, Seema Verma, said this is a clear example of untapped innovation. Now, you may be aware of more data that's come out of CMS that some of these leniencies are here to stay in terms of what is and what's not covered with telehealth. So far, nothing has changed. But what COVID really did for us were two things. The first was that we all know telehealth has been there for some time, but not everybody has been using it. And one of the primary reasons was the lack of insurance coverage. So when we did telehealth starting 2015, 2016, of course, the donor workup, the donor evaluation are all billed to the recipient insurance, but the recipient insurance in kidney transplant world, 70% of the times is Medicare. So it's not covered. What we were doing in terms of the telehealth donor evaluation, the physician evaluation piece was not covered by Medicare in terms of the charges. So we were doing it in billing our transplant program, and we were writing it off because we really wanted to make it easier for the donors. However, when the insurance coverage kicked in, that has been a game changer for telehealth. And the second thing was the consumer willingness. And by this, I don't only mean consumer as the patient, I'm also talking about the providers, because this is a provider, whether it is a physician or it is a non-physician provider, along with the patient, it takes two of them to tango. So with telehealth, with COVID, there was no choice. If you wanted to see your doctor, and we had all these restrictions in place, many of them preferred to now do telehealth with their doctor rather than take that trip down in the early days of the pandemic. So things that you were not used to, you suddenly got used to. Even from a physician standpoint, physicians who did not want to try telehealth because they were very comfortable in their workflows, there was no reason for them to change and try this, now had to do it. And this is not just a 1 week or a 2 week thing. It's now been 10 months. And I think that's a long enough time for us to have our habits ingrained in developing a comfort level with telehealth. And I do expect that even post-COVID, this is here to stay, because many of our patients now have gotten used to the convenience of telehealth. Next slide, please. So what did we change for our donor evaluations during COVID? Not much. We still do the same thing that we were doing before. And because we had the first mover advantage at Jefferson Transplant Institute, because we had been doing telehealth, we just had to tweak a few things and just do it at a much bigger scale, which Jefferson Health was able to support us because we already had the infrastructure for telehealth established. We still did the health questionnaires, the basic labs. Our team was contacting the donor through a telehealth safe platform. Sometimes it was a secure Zoom, and we would do all the consents through that. Our ILDA will call or set up a secure audio video Zoom session. We were trying to dig up PCP records. If we did not have PCP records, we were not really asking our potential donors to go to a new PCP during COVID. We would just bypass that step and do our best to do a telehealth physical exam during their evaluation. Again, we did have the multidisciplinary meeting, provisional surgical date, and sometimes starting end of May/June last year, when we started putting our living donor cases together and going forward with the living donor piece. As you know, most transplant centers had put a break on their live donor program towards the end of March and April and May, and we were no different. So when we started to put this back together, this is when we started to have our team meetings and studies, and we got the donors in about 10 days before, and we would do all their pre-admission testing and workup all in one day. We did add the step of testing them for COVID about 2 weeks before for pre-admission testing, and we are also doing it 48 hours before their intended surgical date. And of course, a donor flew in if they were coming from a different city, maybe 10 days before, but we minimized and we continue to minimize the number of visits a donor has to make to the transplant center. Next slide, please. I want to talk to you about the post-transplant visits. So just like before COVID, we were doing donor evaluation. Similarly, we had also been doing post-transplant visits for our patients. Now, these were the patients who were, again, those who were not very good with follow-up with us, those who could not take time off from work, or they just lived too far off. And if a patient requested, I want to see you, but I'm not able to come down, we would offer them a telehealth visit. And we had a good protocol in place for this. Most of our long-term outpatients, post 3 months, are encouraged to get their labs about a week in advance. So they get their labs a week in advance, and our Jefferson team contacts them to make sure they're set up for telehealth. And a day prior or on the morning of the visit, our coordinator or a medical assistant would contact the patient. And this last box is really important because this made my life and our life so much easier as a physician when we were doing this telehealth appointment. They would update the medication list. They would put in any potential refills that the recipient was requesting. They would ask for a weight and a blood pressure. Our recipients go home with a blood pressure monitor as well as a scale. So they're able to get that to us. They confirm that the labs were in the system. So in a way, it was like virtual rooming. And then we as physicians would go in and log in, and then we would do a telehealth visit. Next slide, please. So we had this set up, and then when COVID happened, we followed the same protocol. The only difference was that we identified a telehealth attending and an in-person attending. And we have a common pool clinic for post-transplant patients, which is probably no different from other transplant centers. So we would say, okay, today, Dr. So-and-so is only going to see telehealth patients. So they will be in their office, they'll have their iPad and their coffee, and then they would do their telehealth visit with the door closed. It's really important to simulate the experience of how you would see a patient. So you should not be doing these telehealth visits with patients in a public place, at the nurse's station, or in a conference room with people walking by. So those little things are important to observe. Close your door, give them the privacy that the patients want, and tell them that, hey, I'm in this room, my door is closed, there's no one here, no one can hear you, and do that visit. It helped that we had a telehealth attending identified so that that attending did not have to go back and forth between patient exam room, seeing actually patients, and then running to their office to do the telehealth visit. We follow the same sequence for the ones who were long-term out, labs a week before, but a brand new patients that we were transplanting, at Jefferson, we are able to do their blood work in the clinic. So we have a dedicated phlebotomist who's there, and that blood work is done right there. And again, if it's a telehealth visit, we had the same sequence we followed as on the last slide, which was updating medication list, refills, weight, and blood pressure, so on and so forth. Next slide, please. There was one other thing that we added during COVID, and these were the patients who were diagnosed with COVID. So we maintain a COVID dashboard with the number of kidney patients that have been diagnosed with COVID, and we do active outreach to these patients. So if a patient calls in and says, I've been diagnosed, or they have symptoms, when we send them for testing, we do active outreach by our transplant coordinators calling those patients and asking how they're doing. They document a little note. They have recommendations if the pulse ox is below a certain number, which is usually 93 and below, and 30 minutes later, it's like that, it's best for that patient to go to the ER. If we know someone is positive, we have made an arrangement to ship a pulse ox to these patients at home for home monitoring. And we also add these patients to a weekly telehealth appointments, so that for the next 2 to 3 or 4 weeks, they are able to talk to a physician on a weekly basis. And we also make changes to their immunosuppression based on the clinical indications. And if their condition remains stable, we try to keep them out of the hospital. But if things are not looking good, certainly we try to streamline their admission to our institution. Next slide, please. So what did we do for transplant evaluations? It was really important for us to continue and keep the ambulatory functions of a transplant program functional. This was while we wanted to maintain operations during a crisis management mode. And let's remember that the work here on the pre-side is cumulative. So if you're not doing transplant evaluations, those patients are not coming to see you in any modality such as telehealth. Those patients are waiting for months and months and months, not knowing when things are going to get better. And then when things do get better, all these patients have to be seen. So we went to a model called as the Agile listing model, which is do the minimum, avoid wastage, avoid too many trips, try to dig up records, try to get whatever you can get from Care Everywhere in Epic. We have Epic that we use as our EHR, and try to get it together and try to list these patients. We were especially very pushy with our preemptive patients, that is those patients who are not on dialysis, because we wanted to get them on the waiting list quickly. So in the Agile listing model, our nurse coordinators contacted them in advance. All those patients who had been listing starting mid-March with us for evaluation for the months to come, we converted them to telehealth. Our office staff contacted them and helped them with the infrastructure and or the tech support that they needed. The coordinators did e-consenting, and our entire team on the pre-side would get this patient ready for a telehealth transplant evaluation. They also spent time reviewing medical, surgical, family history. Everything that they would typically do in person, they ended up doing via telehealth. Next slide, please. As I mentioned, for the preemptive patients, we did minimal set of labs for them, maybe just a blood type, HLA, and we would list them the minimum that was needed for listing. We dug up all records, we would inactively list them, and we expedited evaluations for any living donors where the pair came in or virtually came in to us that I may have a living donor. We try to evaluate that live donor evaluation too. If we felt in their workup that they needed any consultant input, those consultants were also set up to be seen via telehealth. So everything that we could do, we tried to push through with telehealth. We made it to an active listing. And then the only thing remaining for that patient was an in-person physical exam. When things got better, we were able to get that done, get that patient in. And just for a physical exam, it was a quick in and out visit where they met with the physician. Next slide, please. So in a way, the summary here is that you can use telemedicine right from referral to waitlist to post-transplant, including workup for living donors. In all the spectrum, it reduces the travel cost. There is a timeliness to evaluation. It makes it really convenient for the patient, whether it is a donor or a recipient, to get their care where they want it at that time, even from the couch, if that's what they want to do. And overall, it increases the productivity for everybody involved. What we've learned through the COVID times, it is something that we are still continuing, and I think a large portion of this is going to stick with us. So that was my piece, and back to Dr. Yadav now. Thank you. Next slide, please.
Next slide. So thank you, Dr. Singh, for that comprehensive review of the workflows. I'm going to talk about the another important aspect of telehealth. So we all know that it's good, we need it, but we can continue to do what we are doing if we are able to bill for it well. So what did we do about billing? That's a very common question. So we were asked by the institution, and based on the new CMS rules, that you bill for a telemedicine visit like you would bill for an in-person visit. Use the same codes except for the consult code. And then at the back, behind the scenes, the Epic or whichever electronic health record that you use, that would kind of adjust based on your documentation, based on the complexity or the time, they would change it if needed. With the new CMS guidelines, you can edit your note based on the complexity or the time based. The billing for the telephone code is very variable and it's not very well defined. And again, it depends on which state. Every state has a different rule. So we need more definitive guidelines from CMS about how to bill for the non-video platforms like a telephone call or just any other means of emails or any other modes of communication. So that's not well defined. Um, COVID-related billing are constantly changing. Currently, the guidelines are kind of defined till end of Feb. Before after that, we don't know. So we'll have to keep updated. You can check at the Federation of State Board of State Medical Boards or AMA websites for more details. Before COVID happened, our patients were some of the patients who were traveling far or who had to take a day off from work. They would rather pay for the one-time bill for the telemedicine rather than coming for the in-person visits. Again, these are the patients who were completely stable. So they were doing that and we were fine with it. So there might be some patients who might be willing to pay out of pocket costs if it saves them a visit or if it you know alleviates their anxiety about coming to a hospital setup. Next slide, please. So this is our summary of our experience during the pandemic. So, our clinics started to kind of close mid-March. If you see, we were doing some telehealth in Jan before that as well. So not too many, but we were doing some here and there, again, based on the patient's request and clinical necessity. But mid-March, we started converting our clinic visits from in-person visits to telemedicine visit. In the last 2 weeks of March, the uptake was slow. We were still developing our workflow. So we went from 0 to 21% in the second half of March. And then in April, we amped up to 99% of our clinic visits were um, telemedicine visits. And these were not a small number. We did 300 plus visits during that time for the post-transplant care. So you see, we had the infrastructure built up. There was institutional involvement. They changed and modified the telemedicine platform so that they can handle these much volumes. And we continued to do that way until June when we started transitioning partly in person and part telemedicine. We still do around 30 to 40% of telemedicine visits. It's a hybrid model that we are following. There are certain clinics which are 100% tele, and then there are certain clinics which are around 40% telemedicine. So we are still doing it. We are not back to 100% in person with these surges and spikes. And we were able to publish our experience of these workflows and how we amped up our volume during COVID in the Journal of Telemedicine and Telecare. Next slide, please. So what are the barriers? What did we experience, and what are the feedback that we get from other institutions? What are the things that we face, and how do we overcome them? So next slide. We'll spend a few minutes talking about this. So the first critique, as I mentioned in the beginning, is the lack of exam or the limited exam. So, we physicians or anyone else in healthcare we are so used to the conventional way of practicing medicine that we have to be, in front of the patient, touching them and, doing a physical exam. But during this COVID pandemic, it made us more creative, try to adjust to the growing demand. And we developed, and I'll go over in detail about how can you do a complete exam, sometimes very, very comprehensive, more than in person. But first, there are some website manners when we do the telemedicine. So we call it website exam. So first of all, when we are doing a telemedicine, I know we all have to document, but making sure that you have an eye contact with the patient helps them develop that trust. They know you are talking to them, you're taking care of them, so they feel like they're in front of you. Kind of simulates the real life situation. You have to position your webcam properly, whether you're on a tablet or an iPhone. Make it so that you're at your you're making an eye contact. Your camera is facing your at the level of your head and eyes. You kind of position your electronic health record in a way that you can talk and review their chart while you're talking to them. You should be in a nicely lighted up room. Don't sit behind in front of the window. Make sure that there's enough light in a private place. And the background, there shouldn't be too much noise or too much of a busy thing going on. So make sure you're in a same kind of environment which you would usually see your patients in the clinic. The patients, when they see you, their interface is a little bit different. So we have Epic in our system. They have this My Chart app on their phones or iPads or laptops. So they see us through that. And our interface was, again, through Epic, or what they have in a Haiku app. So we see the patients on a whole screen. So there's nothing else that we see. So those were our interfaces on each side. Next slide, please. So this is a very, very comprehensive list, as we got this published, and it is there for everyone's review. We called it website physical exam. I'm not going to read out the whole thing, but you just by looking at a person in their familiar or home environment, you can deduce a lot of things. You can observe, and you can ask the patient to help you with the exam. So patient assisted exam can help you get a lot of information. So general appearance, vitals, besides all those things, you can ask them to push on their shin to look for edema, do a abdominal exam to see if they have a certain tenderness, and ask their family members to hold the camera while they're doing it. So there's a lot of information that we can get on these video telemedicine platforms. And we've been pretty successful in doing these. They can do a fistula exam, the graft exam. They can show you any skin rash that is developing or any other thing that they want to address. During these encounters, you can also see what their home environment is. In the new transplants, how many floors are they climbing? Are they getting short of breath when they're talking with you? What is their socioeconomic status? What is the background? Do they have an attendant or someone to take care of them in their home environment? So there's a lot of other kind of ancillary information that you could get during these telemedicine visits. So when someone says that the exam is a limiting factor, that's not entirely right. Another note on in this for the exam is, when we talk about live donor evaluations and the lack of exam, that, how can you approve a donor for donation without examining them? There's a lot of ways of doing it. If the patient was seen by their primary care physician, you can use their exam. Donors go through extensive workup. They have all these imaging studies with them. There's very little that the physical exam would add on to it. And you can leave that exam to the time when they are in person, coming to see you in person, and you can do your full exam there. But I don't think, and as a group, we don't think that that should preclude them from getting evaluated remotely while we are waiting to get all the studies done. Next slide, please. So the common misconceptions, I like to see them as physician or the provider misconceptions, patients misconceptions, and the institutional misconception. So if you divide like that, it's easier to go over. And this is a beautiful table published in Kidney 360 last year. It gives you the most common barrier is infrastructure. So you have to kind of talk to your institutions would go like, it's so expensive to establish a setup for telemedicine. But if you think about it in a logical manner, or if you can convince the institution, it's a upfront expense, but in long term it does pay. For every transplant done, the institution gets paid for that. So it's an upfront investment which gives you long-term benefit. So the institution should look into that. The medical licensure was another critique to telemedicine exam, which kind of went away with COVID. And there's a lot of advocacy and policy movements at this point to completely get rid of these, because we saw how important telemedicine platform is, and how it's a tool which can kind of surpass all the boundaries and provide healthcare to people who really need it. Payment models, again, during COVID, there were a lot of reforms. I think if we can continue with these things, I think we would save a lot of Medicare money and provide the care that the patients need. Our own personal biases come into play, that we are not comfortable in seeing or making decisions when we are not seeing the patient or not touching them or examining them. It's a personal satisfaction about how we perceive medicine is to be delivered, or healthcare should be delivered. So we have to overcome our own barriers and use our past 1 year experience to kind of use this tool effectively. And the patient's concern, I think you have to, any institution who wants to do telehealth has to have partnership from the patients and have their participation, inform them, reassure them that they are getting the best care, and get all the data and get surveys and do the quality assessment if they are happy with it, and change your workflows based on their feedback. So ultimately, patients would like to, have telehealth because they were all scared about coming to the hospitals, and they've kind of realized how easy and how good of a care they can get by using telemedicine platform. Next slide, please. So, we all talk about COVID pandemic, but the other topic which gets kind of, not so highlighted is the second health crisis. Or what about all the patients who did not get the care they needed during the COVID pandemic? How about all the elective surgeries that were postponed, or the heart failure patients who were not seen, or our own dialysis patients who kind of did not get the care that they needed because there was just nothing else happening other than the COVID. So we all saw the second health crisis once the surge was over, and we saw this increased number of admissions during that time because of all the care that was missed, all the canceled surgical cases, preventive health care. So telemedicine is a good way of kind of keeping up with that, making sure we can deliver some of the care. Obviously, we do not and cannot do the surgeries, but there's a lot of other care that we can provide to our patients, and kind of overcome the second health crisis that we are going. And this is the only way to kind of find a balance in this new normal where we have this hybrid system. Next slide, please. And finally, the telemedicine as a is a growth strategy, I think, and our institution and our group believes that this solved a strategic problem during the pandemic, but I think it kind of reaches out beyond the pandemic. It solves a lot of problem about not having enough clinic spots, or not doing the whole patients cannot come, the patients who had difficulty coming to you, or too sick, or too healthy to come in, and they don't want to come in when they are scared of having the exposure to COVID. So this whole telemedicine is a model which brings care to the patient, or not bring the patient to the care. So it follows that philosophy. We at Jefferson had the first mover advantage, but I think everyone can benefit. You build small, and then you start changing the culture of the institution, and your own overcome your own barriers. So you build a system, and then patients will come and follow. You cannot be perfect, but we can try, follow get the feedback, change based on the feedback. Payment reforms might or might not stay, but I'm sure the patients and people who really care about would like to carry on, and would like to be our partners in this endeavor. And a hybrid model is the way to go, and is the way for the institutions and the organizations to provide the best healthcare that our patients deserve. And I think that was the last slide. Any questions?
Thank you so much, Dr. Yadav and Dr. Singh. And that was such a comprehensive overview, I think, of telehealth and telemedicine implementation. So thank you so much for taking the time to kind of walk us through that. We're now going to go ahead and transition to our Q&A discussion, but I'd just like to remind folks that if you do have any questions for either of our presenters, please be sure to submit them using the Q&A feature. This is a reminder that's going to be located at the very bottom of your screen in the Zoom navigation bar. So while we wait for your questions, I think we do have a few in the queue already. So looking forward to receiving a few more. And one additional comment I'd just like to make, for those of you who may not have completed the poll just yet, if you are participating in a group, if you can please just complete that poll and let us know how many people in your group are actually participating, that would be greatly appreciated. With that said, I'll go ahead and turn it back to Laura to facilitate the Q&A discussion. Thank you.
Yes, thank you for a great presentation. We do have a few, so I'll go ahead and read these to you. The first question, have you measured no-show rates for office clinic visits versus broken telehealth appointments, pre-COVID, COVID, and now?
Anju, you want to take this one? I can fill in later if needed.
Yeah, that's a very good question, because we did mention about the no-shows. I don't think we have had a number, and Dr. Singh can definitely chip in. We haven't measured what our no-show rates was, but overall, I think we have seen a very good uptake in our patients during the COVID. Before COVID, we had few patients who are our regular telehealth and telemedicine kind of patients who use those platforms on a regular basis. So we were kind of exploring, but again, the payment and the insurance was the biggest hurdle at that time, pre-COVID. During COVID, I think we had a pretty good success with this. The only people who no showed were who were technically having troubles logging in and continuing the visit, or someone who how the clinics got backed up and we couldn't get them on time. Um, the second question was, with telehealth, have you seen a shift of patient contact or consultations from physicians to APPS for otherwise stable follow-ups? I don't understand the APPS.
It's the advanced practice provider. I'll take that one.
Yeah.
I wish I could say that for our program we have APPs, because I think APPs do such a wonderful job in taking care of the patients. We have some on the inpatient side, not on the outpatient side. But I have no reason to suspect that with telehealth, this shift would not be there. In fact, many of the patients would probably prefer to see APPs just because of the long-term relationship that they have formulated with the APPs. But I am aware of other programs whereby there is clearly a preference to see APPs, and I suspect that this is something that will continue. And perhaps the more complex patients may be the ones that could be seen by the physicians, and the stable ones could be triaged by the APPs, I suspect. Going back to the last question, there is one comment that I do want to add. When we shifted from doing the clinic in person to telehealth, there's one thing, that the patient was always on time. This is not the time that the patient is getting stuck in traffic and you as a physician are waiting for the patient. The patient, unless they have tech issues, is always going to be in time. There are times I have done telehealth with one of my patients who would never show up in clinic. She was a younger patient and she would be waking up in bed and she would have her telehealth on. And I could clearly see that she's just woken up. But she said, Dr. Singh, for you, I'm logging in. And this is where the compliance piece comes in, that it is so convenient for the patients to be compliant now because they have that technology at their fingertips. We did struggle when we had this mixed model of the same attending doing telehealth and in-person visits. There were times that our patients waited for half an hour, 45 minutes, and that is why we had to pivot quickly and just assign a telehealth attending so they were not going back and forth. And if the patient logged in, waited, logged off, we would call them and say, we are sorry. We know this is hard and you were waiting for us. We are back on. Can you log back in? And they would do that. Going to the next one. How many states are you serving with telehealth and how do you handle multi-state licensing? Do you have a specific program for e-consent? Dr. Yadav, I'm going to take this one, okay?
Yeah.
So currently, as you're aware, federal mandate, you can do telehealth anywhere. State mandate, you have to see what your state says. For us, the guide, so you have to follow the guidance from your institution. The guidance from our institution was you could go into Jersey, you could go into Delaware, document that this is during the COVID-19 pandemic and the state lines are being crossed. So the documentation is extremely important during this time. Having said that, Dr. Yadav and I both got the emergency New Jersey licenses. Jersey came out. We have a lot of patient population in Jersey. We even have satellites in New Jersey whereby we see both post-transplant follow-ups as well as transplant evaluations. So we got when we had the provision to get an emergency license, and it was a very easy process. And thank God that they did it because it made me feel safer crossing state lines. Although the mandate was there that you could do it, the provision being there, we did it. So currently we are serving these 2 additional states. In addition to that, we do have some patients in Florida, and those when we are seeing for transplant evaluations, we sort of know that we are not licensed there. But at the same time, we are doing it because currently with telehealth, we are able to do it during the COVID-19 pandemic, and we keep very strong documentation. In terms of the e-consents, this is a very important topic. I would say as at your institution, if you decide to do it, the key is patience. These things do not happen overnight. Your legal department has to get involved. With Jefferson, the first change we saw for e-consent was in the research world, that the consents have been done via e-consenting. Personally, I've signed many over Adobe. That's one company that is used, and then some other places use DocuSign. In fact, last year when we were lecturing other programs about pivoting with telehealth, this was a very frequently asked questions, and some programs were ahead of us in terms of already having e-consent. I believe MGH was using DocuSign or Adobe. We are almost close to having this figured out for our institution. And as I said, patience is key to get this done. In the early days of the pandemic, what we were doing was our coordinators through a secure email were sending the consent to the recipients or the donors, and they would sign it off, take a picture, send it back, and we would scan it up to the chart. That was the old way of doing it, and we have moved away from that. Let's do the, what's the next question? Laura, I'll wait for
go ahead and read that to you. Okay, next question. Thanks for the great presentation. Were there specific examples of problems that you encountered when you met a living donor in person after seeing them initially during telemed?
I think the one, I wouldn't call it a problem, but the one thing that you have to be careful is about the weight and the scale, right? So, you know, home weights can be different from the in-clinic weights based on the BMI cutoff that you use for your institution. Sometimes that confusion can happen, and the height, that's really important that, you know, you measure the height. So we do not go by self-reported height. In our donor population, as well as our recipient population, our office staff has been instructed to always check the height when they come in so that we have accurate documentation. So we had some numbers that were off initially, and it sort of sometimes didn't meet the criteria, and a weight loss goal had to change. But other than that, I really can't think of any other big reason. In fact, I do want to mention that our social workers felt very comfortable and preferred to do telehealth with donors, because for them to be able to see the donor, to see their expressions with their mask off is extremely important. It made them feel that they were doing a very comprehensive evaluation. So even now, our live donor social workers go and see the donor in person, introduce themselves, but for a full comprehensive live donor evaluation, they actually, they do a Zoom session with them, an audio video Zoom session, so that the mask for the donor can be off. And I see logic in that, why they would want to do that. I see it both ways, but I think it's something that they feel very comfortable and important as part of donor evaluation, and we've been very supportive to make it happen.
I'd like to add to that. So that's actually the biggest concern that we had, that how do you examine what about their body mass index, height and weight. So the one thing was that we would ask them to go to their primary care physician so that they can get an accurate height and weight. During the pandemic, it was not always possible. You can also ask them to go to certain labs and order, you know, there's a lab order, you can just order vitals and they would do it in a lab where somewhere else does it. I also heard about certain programs sending them to their fire stations where they can get just height and weight. And so there are ways of, you know, kind of overcoming all these barriers and hurdles that we might have in these evaluations. And that's why we think that should not be the reason to kind of slow down or hold up donor evaluation. So
I did not know about the fire station.
I learned about it recently. Yes.
That is all of the questions we have submitted, which is perfectly on time.
Great. Well, thank you, ladies, so much for taking the time to address some of those questions. I would just like to, before we conclude, on behalf of the Alliance, I'd like to extend, once again, a huge thanks to the two of you for your presentation, for taking the time to put it together and kind of share your insights with us. And Laura, we want to thank you as well for not only joining us, but to help to facilitate today's discussion and the Q&A. So a huge thanks to the three of you ladies. And as always, to our participants, we thank you for joining us, and we look forward to hopefully seeing you at our next webinar offering. I hope you all enjoy the rest of your day and have a great weekend. Take care and stay safe, everyone.
Thank you so much for inviting both of us.
Thank you, everyone. Bye-bye.
Bye, everyone.
Thank you.